Hey, good evening, everyone. I'm Marcy Rubik. I'm the Executive Director of the Limb Preservation Foundation, and it is my pleasure to welcome you this evening. Thanks so much. We are very excited to share a lot of great information and resources with both patients and providers, and we have a great lineup this evening. So we are going to kick things right off, and the first thing that I'd like to do is introduce our, I'm sorry, let me just say a few words about the Limb Preservation Foundation. In case you don't know, we've been around since 1986, and we provide lots of supportive services to patients. We provide patient assistance, which is direct patient financial help to patients while they're in treatment. We have peer support, and care packages, care bags, and scholarships. So we can talk a little bit more about that if you have any questions, but we would love for anyone new to the Limb Preservation Foundation to learn more about us on our website and let us know if we can be of help to you. So the first thing I'm going to do is introduce you to our moderator this evening. Michelle is the Director of Therapy Services and Wound Care at Swedish Medical Center. She is a practicing physical therapist, and she manages many different departments at Swedish Medical Center, including physical therapy, occupational therapy, speech therapy, rehab, and wound care. So that is a lot, and she is very passionate about patients. So we are very excited to welcome Michelle Oliveti.
Good evening, Marcy. Thank you so much. I'm happy to be here with you all this evening. Our goal is to share a variety of information with you so that you can apply it immediately after this webinar. I will be moderating the session, as Marcy said. Please be sure to add any questions that you all may have in our chat section. We will answer your questions during the Q&A at the end of the webinar. And you'll soon be able to visit the program on the Limb Preservation Foundation's online learning lab, and you can review it there. With that, let me share a few words about our presenters. First off, you'll be hearing from Dr. Colby Hansen. Dr. Hansen is joining us from the University of Utah, Craig H. Nielsen Rehabilitation Hospital. He's an associate professor in the Division of Physical Medicine and Rehabilitation. Dr. Hansen's clinical interests are in amputee rehabilitation, concussions, and other forms of traumatic brain injury and electrodiagnostic assessment. His research interests also include rehab along with medical issues of amputees. After Dr. Hansen, we'll be hearing from Dr. Bill Tettelbach. He's the Medical Director of Wound Care and Infection Prevention for Encompass Health and Rehab Hospital in Utah, as well as the Principal Medical Officer for MiMedx. Dr. Tettelbach's clinical interests are in infectious disease, and he has been in practice for over 20 years and retains an academic appointment at Duke University School of Medicine. Lastly, Guy Lev is a physical therapist who directs osseointegration rehabilitation as a team member of UC Health's Limb Restoration Program. Guy is actively providing amputee care and rehab. He also facilitates a large amputee support group. Guy is an active researcher and lecturer in the field of amputee rehabilitation at the University of Colorado Physical Therapy Program. Welcome panelists and welcome attendees. With that, I'm pleased to introduce Dr. Colby Hansen.
Thanks, Michelle, and thanks to Marcy and the Limb Preservation Foundation for putting this together and for giving me the opportunity to present some of the things that we've been thinking about and working on at the University of Utah. So my talk today will be about the impact of residual limb sweating or hyperhidrosis on amputees. By way of disclosure, some of the work that I'll be presenting was supported by a grant that we received from the Department of Defense. So when we think about sweating, with amputees, there's actually a lot of problems that can present to them. Mechanically, sweating can lead to excessive movement in their prosthesis, which can naturally lead to issues like pain or skin breakdown, or frankly, even malfunction and fall potential with their prosthetic if it slips or isn't staying on properly. There can be cosmetic quality of life issues like odor and difficulty maintaining good hygiene practices. It can be a nuisance related to folks who are active and wishing to exercise. And we've had many who have expressed to us what a frustration it is to be doing a workout and then have to stop and take their leg off and dump out the sweat and dry it off and put it on and go on about their business. From a broader health perspective, sweating can also be the instigator to other skin problems like rashes and superficial infections and things of that nature. So it really can be a pretty significant problem. Some old research we did, we tried to quantify how big of a problem it was for amputees. And the scale that most dermatologists use when they talk about hyperhidrosis uses this scale here shown on the right, the hyperhidrosis disease severity scale. It's a scale that goes from 1 to 4, and basically the higher the score, the more sweating impacts and interferes with function and daily activities. And what you see on the left are some plots that correlate that score in a population of amputees in our region to questions related to how they perceive sweating to interfere with their prosthetic fit or their prosthetic function. And so this HDSS score correlates quite well with those measures that are specific to amputees. In terms of management strategies, there are some pharmacologic options that can be effective. The simplest and first thing that would be appropriate to try are topical antiperspirants. Topical antiperspirants generally work through an aluminum salt ingredient, which, as shown in the cartoon on the right, comes down into the sweat duct and essentially clogs it off and thereby inhibits sweat production. They are generally modestly effective. They can, in some instances, be a little irritating to the skin, and that's why we instruct patients to apply the antiperspirant at night and then wash the limb off in the morning to wash off any residue on the surface of the skin, but that active ingredient has gotten below the surface of the skin and can be then used for the most part without any side effects. So we undertook a clinical trial specifically in amputees where we looked at the effectiveness of aluminum chloride, a prescription strength version of aluminum chloride called Drysol, and compared it to a placebo. And we had patients alternate between placebo treatment or active treatment in a crossover trial over a 4-period design. So every 3 weeks, they opened up a new bottle of study medication, which was either placebo or active treatment. And the patients were blinded to which condition they were on. As providers, we were blinded to which condition they were on. Only the pharmacists knew which condition the patients were getting in what sequence. And then we did, kind of standardized outcome measures every 3 weeks to get a sense of how their sweat experience was changing. So these are some of our results expressed in terms of change in HDSS score. So a negative number implies that there's an improvement from baseline in their HDSS score. A 0 is there's no change from baseline, and then a positive number, there's actually a worsening from baseline. So we had, as you can see, the cells there that are in red are those patients who had some reported improvement from baseline in the active treatment column versus the placebo treatment column. And they're fairly similar. We had about 33 or 56% rate of positive response to the active treatment and 29 responders or 47% in the placebo who were responders. That number by itself was not statistically significantly different. When we did a more detailed analysis accounting for other baseline variables in a method called a regression analysis, we were able to demonstrate that although modest, there was a significant treatment effect in the active treatment group in those who received aluminum chloride that was superior to placebo at improving their HDSS score. So again, although these results are modest, it does provide some evidence that this treatment can be a reasonable first-line approach to managing hyperhidrosis. The other study that we did used a more invasive treatment with botulinum toxin. Botulinum toxin is an injected medication. Most people are familiar with it from the perspective of cosmetic effects, but it actually has a lot of pharmacologic value for a variety of conditions. The cartoon on the right just shows how botulinum toxin acts at a certain protein at the end of a nerve connection to either a nerve muscle connection or nerve, in this case, it would be like a nerve sweat gland. Nerves turn on sweat glands and tell them to produce sweat. So Botox is the only FDA approved botulinum toxin. There's actually several botulinum toxins out on the market, but Botox is the only one that's FDA approved for hyperhidrosis in the axilla or the armpits. When we consider applying this to amputees, though, it's a kind of a unique challenge. An armpit is a fairly small surface area, but if you think about an entire residual limb, that's quite a large surface area. And so the amount of drug you would need to treat the entire surface area is quite big. And that leads to A, a lot of drug, and B, a lot of time, and for some people, significant discomfort. So we adapted a strategy to try to identify and visually see where the sweat was coming from the most. And that's using a test called the iodine starch test, which is illustrated here. So basically, you can use iodine, painted iodine onto the skin, let it dry, dust it with cornstarch, and then put this little sheath on top of that, have them walk in their prosthetic for 15 minutes, take it off, and then you start to see areas that are dark that you can kind of see in panels A, B, and C. And that dark is the sweat reacting with the iodine starch, and that gives us a visual of where the sweat's coming from the most. And then we can target the botulinum toxin to those areas. And then panels D and E show the same type of test done a month later, but without that kind of dark response, showing that there is a reduction in sweat production. So these results are really pretty impressive. These are showing the HDSS score and the vertical axis, and then along the x-axis, you see the improvement of our HDSS score from baseline on the left to week 4, 8, 12, 16, and 20. And I will say these are pretty significant improvements. We did, some of our other outcomes included these questions related to specifically how sweating interferes with their prosthetic fit or function. And similarly, we see quite a dramatic improvement in the patient's reported sweat problem. So we're really excited about this as a treatment option for patients, and I've had many patients express to us, what a difference this has made, often for several months before that sweat starts to creep back up. So that's my presentation, and happy to answer questions during the Q&A period.
All right, so my name again, just to refresh, is Bill Tettelbach. Again, I want to thank the foundation for creating this wonderful forum for patient education and outreach for the community. So again, my background is mostly actually wound care and with infectious diseases. I am going to really talk about, from my experience, 20 plus years of being clinically active in wound care and treating all types of wounds, is really how to avoid complications for those who develop wounds, especially those that become chronic, and how really you yourself as the individual who's suffering from these wounds, or folks that you may accompany who develop wounds, and being the best, or be your own best patient advocate, or those that your loved ones that you're involved with these type of situations. Again, for disclosures, I am a speaker and consultant for my medics, but also a little bit about my background. I am actually now, have been working with my medics, and not in the capacity of the principal medical officer in the past, but actually now I'm the executive medical director for the mountain division within HCA. So I have Alaska, Idaho, and Utah, and oversee all the wound and hyperbaric service lines within that. So I'm shifted more into the clinical space, and this is even more relevant. And I'm giving some examples in this of what have just in the last couple of weeks that I've experienced. So we're going to hit on, look at the impact of lower extremity amputations real quickly, how they, especially in the diabetic population, this is a big problem within the more aging population, those who are not now may be at risk for that later on. Looking at the influence of debridement, which I think advocacy and having knowledge and the power of knowing maybe where you want to speak up, and then really how this can be your own advocate or someone else's advocate can improve outcomes when those have clinical complications. So let's just, kind of like overall, but within the diabetic population, those who have chronic wounds and have complication of those chronic wounds and have to undergo say a major amputation, not so much traumatic, but this is a non-traumatic amputation, this really affects these individuals' 5-year mortality rates. So actually, your 5-year mortality rate in this situation can go up to 56.6%. Or those who say have to get like a transmetatarsal amputation from a chronic situation, that can actually up your mortality rate to 46.2%. Just developing a chronic ulcer, which a lot of us, in our older, as we get older and are diabetic, that can increase your mortality rate by 30%. That's all these numbers are can be higher than a lot of cancers where you get treated for and have a 5-year mortality rate or outcome. The optimal, or the optimistic side of this is that a lot of these type of amputations are really avoidable when you are actively engaged, get the right people, and you're asking the right questions. So I'm just going to give a quick example just from last month. This is an individual who showed up at a long-standing superficial ulcer on their leg. We've got this cleared up literally within days. They came back next week, 5 days later, but they had developed this sort of, you can see this bump on the far right side, and it looked very benign, was not really paying much attention to that. We would move on and see how this would progress. But really the patient and the wife of this patient really said, we're really concerned, we would want a biopsy. And it really kind of triggered a thought process of clinical treatment. And we actually went ahead. Without that prompting, we would not have done it. And this benign looking lesion actually turned out to be an invasive squamous cell carcinoma. And if this had just been ignored, and this could have got, metastasized or gone and spread further in the lower limb, creating a larger defect for surgery that was needed. Fortunately, it was caught early on, and this patient can actually go under a more localized procedure to remove this. But this is where advocacy can really change the outcome of the patient being treated. Now, I want to, we recently looked at and did a retrospective analysis looking at individuals that were being treated for chronic diabetic ulcers and were receiving debridement, and how did debridement actually impact the outcomes of this. And we looked at over 10 million patients, actually ended up evaluating over 80,000 individual patients with a lower extremity diabetic ulcer, and looked at how the debridement interval affected, say, amputation rates with this. We also looked at prospective data of past studies, and this is kind of a meta-analysis first, then a retrospective analysis of the data. This is a little bit looking at the prospective randomized controlled trials, where when you were utilizing advanced therapies, using a protocolized data, you could get up to 81% closure rates of these wounds in the lower extremities. But when you combined good debridement practices on a weekly basis, you can see the 81% closure rates at 12 weeks actually bump up with good debridement to 96%. Even in those who are getting standard basic care without advanced treatments, this went from a 48% closure rate to 65%. So it really makes a big impact. And this is when you're debriding these wounds, getting down into removing that dead or necrotic tissue, and they're not doing that within the time frame of these wounds. You really need to maybe question, is there more that can be done, or get a second opinion. So this is kind of just looking at that prospective data when you looked at outcomes and how it impacted healing rates. The top of the list here was debridement versus adequate versus inadequate. And you can see with this hazard ratio, the 6.19, that basically means that you are 6 times more likely to get closure of that wound when you have good debridement practices being applied to that. So this is looking at the Medicare data. So when you go see someone in a wound care setting, one of the basic tenets is debridement. And there's past studies showing that the frequency of debridement impacts the outcomes. And so we looked at these 82,000 episodes of care, thinking that most patients are going to be getting at least weekly or biweekly. But it was kind of startling to look at the data and see the fact that only 21% of Medicare patients with a lower extremity ulcer, so this could be actually on a BKA stump or on a foot, only 21%. So that's much lower than what it's almost startling in the sense of how low this was and what we thought was routine protocols that most wound care centers were following. This is just an example of a patient that actually came in last week where they had a chronic wound. They had neuropathy in the lower, meaning they can't feel the pain or any sensation in the lower extremity. They had been walking around New York on a long extended holiday. The patient did not want to come in, but the patient's partner or spouse encouraged them to come in with analysis. This patient actually ended up having abscesses, osteomyelitis. The white count was elevated. He was actually heading into sepsis. So early intervention kind of turned this around early on for this patient. So again, that's being, your own, best advocate or someone else's best advocate. And here's another example of where getting a second opinion. This was a individual who was heading for a partial calcectomy, meaning that they were going to cut off half of the heel bone of the foot because it was infected in a 3-month-old wound. Before the surgery, the patient was still questioning what were any other options. The surgeon called myself. We had a discussion. I looked at the pictures, and then we decided to hold off on an aggressive amputation at that point. We went ahead then and saw them in the outpatient setting. We did, we started empiric antibiotics. We did aggressive debridement, and lo and behold, within several months, we got this with a sort of longer journey, but we got this completely healed, preserved the quality of life in this patient. And this is where, asking for second opinions, do not be afraid to do this. questioning your caregiver on other options that could be beneficial. These are all things that you need to stand up and feel comfortable with open communications with your physicians or providers to have, maintaining the best quality of life and have the best outcomes. And I want to thank you. And again, thank you for the opportunity to allow putting the patient first and putting education high in the list here.
I guess I'm up next. Can everybody hear me? All right. So my name is Guy Lev. I'm a physical therapist. I work here in the metro area. And Marcy and LPF was gracious enough to invite me to speak tonight on some of these perspectives on this medical innovation. And I wanted to talk a little bit about leveraging technology in the care of osseointegrated patients. So some of you may know me and know that my primary area of interest and care is amputees, as well as, and in particular, osseointegration. So osseointegration is a novel procedure in itself, whereby we implant a prosthesis directly into the skeletal structure of a person, an amputee. To that, you attach a prosthesis such as a microprocessor so that a person can eliminate the socket and have direct contact between themselves, their bones, and the ground and the prosthesis. So osseointegration so far, despite being really novel, has been a really successful and life-altering treatment for a lot of amputees. It obviously eliminates socket discomfort because it eliminates the socket, decreases donning and doffing time, as you can see in this video, how quick people can take it on and take it off, improves people's walking symmetry and function, decreases their amount of fatigue, and even improves proprioception, or even the ability to know where the foot or the arm is in space, and even the type of surface that that people are walking on. So here's a great example of a patient over a 1-year period. In this first video here, this is pre-osseointegration. She's walking with a traditional socket. Then you can see 8 weeks after the procedure, as she's using crutches, you can already see an improvement in her gait pattern. Here's 3 months after without any assistive devices. And the final video here is 1 year post. And this one is from the side. I know it's not oranges to oranges from the front like the other videos, but you can definitely see the improvement in her gait after a year. But my hope is not just to talk about osseointegration, which I've given talks before, but rather talk a little bit about the tools that we use to study this, which I think is really novel because we have some tools that no one else in this field is using. So one of the things, our primary tool is a clinical motion lab, or known as a gait lab. And what you can see here in this video is someone that is in a gait lab. So a gait lab is, in a sense, thank you for playing it again, is a device that allows us to capture human motion and study it. So you may be able to see that we are able to mark somebody's joints up, and then that feedbacks into a computer. The computer builds a computer model of that individual, and coupled with pressure and force plates, as well as infrared cameras all around, we're really able to capture motion. So and objectively quantify it. So there we go. So this, I'll go back. So this tool lets us get a lot of data. So we really kind of divide it up into like 5 categories: the temporal, kinematic, kinetic, force, and pressure. So temporal are really like things like distance and speed. So pace, speed, stride length, stride width, things like that. Kinematic is range of motion. So how much movement each joint goes through. Kinetic are powers and moments, or the amount of really strength and used around joints. Forces are the body's effect on the ground and the ground's effect on the body as you push off during walking. And then finally, pressures, which is the area, just like in this picture down here, the area where the body contacts the ground and how much force is on each part. And we can do this in a dynamic pattern. So on top of all that data that we're able to collect, we get tons of other stuff. So we're able to get what's called patient-reported outcomes, or PROs, and those allow us to figure out what people's perception of their participation, their pain, their emotional state, their quality of life, falls, function, other such things from the patient perspective. We get functional outcomes, we get clinical data, that's like the strength and range of motion, balance, speed, etc., as well as all the demographic, imaging, surgical data. My point is, we collect a lot of data. So on top of all this that we're able to collect clinically as well as in the gait lab, we actually also use remote motion capture. So technology has improved dramatically, and now just with an iPad or your phone, there are algorithms out there and programs that are able to capture people's movement and motion even through their phone. So what we can do is, even when our patients leave us, and majority of our patients are out of state, we're still able to track their progress and their movement. So that allows us for this continuous monitoring, even when patients are not with us. So we can use this remote monitoring to actually have a therapeutic effect, whereby we can assess people's amount of function or gait or movement or the number of times they go up and down or sit to stand every day. We can track, as you can see with a video, we can actually track their movement from remotely, wherever they are, and look for places where things may change. So for example, we may be able to see that their movement has been progressing in a certain way, and then it starts to deteriorate, and then we can intervene, trying to figure out why movement would deteriorate. Now, the idea with all this data that we're able to collect is actually to be able to put a lot of this information into an algorithm that would allow us to actually predict some outcomes. This predictive algorithm, it looks for patterns and is able to then subcategorize or subgroup participants into certain areas with likely outcomes, so that we could actually do a better job figuring out where they may be or in what way we can intervene. And the more data we have and the more participants that we have, the more that this prediction becomes accurate. So here's like an example of a small pilot study that we did using this predictive analytics in a different population than an amputee population, excuse me. This is folks that underwent total knee replacement. And so we studied 100 people. We watched their changes over time. We used that to create a curve. And then from there on out, as we see our patients, we are able to measure basic things like the amount of knee bending that they can do, the amount of pain that they have, a certain speed on a certain test. And just by collecting this very basic data over several treatment sessions, a certain pattern starts to emerge that is noticed by the green dots on these particular charts that actually eventually predicts what their final outcome will be. So how much knee extension they have, how much knee flexion, what their walking speed will be, and what their pain level will be a certain amount of time out, 3 months, 6 months, 1 year out from their total knee. Now, what we're working on now is to have similar inputs, data, and to do the same thing with our osseointegration program, so that our hope is that by using some of this demographic or history and the gait data, the PROs or the self-reported data that we just talked about, and putting in some of these predictive algorithms, we can actually have better outcomes for our patients. Because, as an example, if a certain data predicts that somebody will have a higher rate of potential infection, then maybe we can start using prophylactic antibiotics with them. So that we can try to nip this potential infection, or potentially say that through the imaging data as well as demographic and gait data, we can see that they have a higher risk of fractures. With a procedure, we may be able to change our treatment protocol, adjust surgical techniques, or potentially use therapeutics to mitigate that and prevent that from happening. So that's my talk, and that's what we're working on, and I appreciate everybody's time, and I appreciate Dr. Tettelbach and Dr. Hansen's talk as well. Thank you.
Thank you, Guy. I appreciate everyone's participation. I'm looking in the chat. I don't see too many questions, but I wanted to shoot some questions out to the group and see if we can get something rolling here. Dr. Hansen, after listening to your talk, what type of provider would a patient or someone reach out to or be best to speak to about hyperhidrosis?
That's a good question. I think preferably if they are connected to a rehab physician or a PM&R physician, they probably would be the most in tune with these options and familiar with these treatments. A lot of prosthetists are very much like up to speed with some of these things, and can at least direct people to the right providers if they're not already connected, say, with a rehab physician, or can get people trialing some of the antiperspirants that are non-prescription based. That's probably the best place to go.
Okay. All right. And is it true that someone who's had some sort of limb loss tends to sweat more after the actual limb loss and the amputation?
Well, yeah, our data from some initial surveys we did indicated that 2/3 of people with amputations reported sweating at least to a mild degree that interfered or caused some mild problems with their daily life. Now, I don't know what the prevalence of hyperhidrosis would be if you look at the entire population, but
Sure.
But 2/3 is pretty significant.
Yes, quite a bit.
Yeah.
Thank you, Dr. Hansen. Dr. Tettelbach, you talked a lot about advocacy, and I think that's definitely hard for any patient population, especially for the patient themselves as well as their caregiver. Do you have any tips or tricks for people who need to speak to providers, or, sometimes people are afraid to talk to their physician and let them know that they have some concerns. So do you have any tips or tricks for patients or their caregivers?
Yeah, I think, we all, when you're in, say, at a clinic visit or in your clinical setting, you have concerns, there are types of situations, I think, where you want to know something or you're asking the questions, but if you are, as a patient, I think, are overly aggressive, and you could almost create a barrier between you and the provider that kind of will interfere with that. So I think I think civility and kindness. And if you're not getting the answer that you want, you can kind of hold off for a minute and maybe circle back with, that's the same, but not exactly the same question, or try to just open up the dialogue to bring interest. And so, just like with that biopsy, one of the things in wound care, you do a lot of education. One of us that we don't biopsy enough, but a lot of that I think is we're thinking about biopsying wounds that don't heal, but not unusual lesions. But if the patient brings it up, it triggers a whole thought process like, oh yeah, I was not going down that path because I just healed this other wound, right? So I think it's I think bringing up legitimate concerns and then not pressing them in an aggressive manner, but yet being very civil in that discussion will always break down any barrier and bring in more discussion. And so communication is the key. Don't be afraid to communicate.
Thank you, Dr. Tettelbach. I appreciate that. And I appreciate your information on debridement. As a wound care clinician myself, I was kind of shocked to see the data you just showed about the debridement not being completed within those first 7 days, and how that could kind of set a patient back. So thanks for sharing that with us.
We were all shocked by that.
Yeah.
That's a standard care, right?
Right.
And standard care techniques we take for granted. So if you're not feeling that basic care is not being given, then strike up a conversation about it. So, hey, how do you usually manage this? Would this have a regularly get debrided every week? Should I come in every week? That, those are kind of ways to prompt the provider to go, yes, in fact, I wasn't thinking that. If you can do that, let's do it.
Right. Some follow-up. Thank you, Dr. Bill. All right. This next question is for Guy. Guy, how would a patient be best approached about being evaluated to be a candidate for an integrated prosthesis?
Yeah, patients get to us from a bunch of different means. Social media is actually a really big one. Obviously, people, look for things or are part of social media groups. And that's one big way that people hear about it and can hear about us here as a program. The other one are from providers in the know, so prosthetists and physical therapists and physicians that are involved in care of amputees are becoming more and more aware of it, and also aware of where things get done, and it's just becoming a much more common technique as time goes on. So in the beginning, it was really only found in Europe, particularly Sweden and the Netherlands, as well as Australia. And the only folks that were doing it here in the United States was the military, Department of Defense, for active duty soldiers coming off. But it's become much more prevalent in other more commercial centers and academic hospitals. One of the system is now FDA approved, so many more hospitals can use that because it's easier to use. And some of the other systems, including the system that we use, while it's not FDA approved, we are working towards that. And so we hope that it will be soon and will be much more accessible to most folks.
The other question was, who makes a good candidate for this type?
Yeah, so the people that make a bad candidate, and bad's the wrong word, who will not tolerate it,
not ideal,
may not benefit from it, are folks that can't heal well. So severe diabetic, especially uncontrolled diabetic amputees, don't do well because you have a stoma or an opening around where the prosthesis exits the skin and connects to the terminal device. So folks like that have poor healing don't make good candidates. The other folks that don't make great candidates are people that can already tolerate a prosthesis really quite well. So particularly transtibial or below the knee amputees that have a nice socket fit may do just better with a traditional socket. So the folks that benefit the most out of this are people that are transfemoral or above the knee amputees, because many of us know that it's much harder to walk as a transfemoral amputee and also it's very much harder to fit a good socket as a transfemoral amputee and can be a more painful fit. The contact points can be more painful than the below the knee. So it's primarily made for those that are transfemoral, that have a hard time tolerating a socket. And so particularly short transfemoral amputees, now you need a certain amount of bone to implant for the implant to bite, but it's not much, it's 10 centimeters, so it's not a huge amount. Yeah, so so short transfemoral amputees where it's really hard to fit a good socket on a a short residual limb end up being the best candidates and the ones that benefit the most out of this.
And maybe someone who has hyperhidrosis and wouldn't need to wear a prosthesis anymore.
Exactly, it eliminates the sleeve and the socket.
Yeah, yeah. The only thing I had left is that someone had popped in and just said that dermatology has also been very helpful with the sweat reduction. I have two more questions. Dr. Tettelbach, what role do you think orthotic management plays in wound healing?
Oh, I think it plays a big, role. I mean, when you, especially, so we have those who are candidates, who are not diabetic and have good healing, but a lot of the amputees that have lower extremity transmetatarsals, these type of situations, they are at high risk for reoccurrence or even contralateral type amputation. So it's so important, especially, I envy the motion lab. I wish every wound center had a motion lab, because if we could actually use orthotics and prosthetics and these type of things to get even gait back, because we do this and we try to level things off, but we don't necessarily take it to the level where we see the gait is even and being transferred the pressure across both areas. So there's torque on the hip, knees, and on the foot. So it's essential. This is literally, as David Armstrong would say, another kind of leader in the wound area. These type of wounds are just in remission, and we constantly have to do things to keep them from coming back. And that's a big player. Even though a wound gets healed, you're not done. You got to make sure it doesn't come back.
That's certainly that's the most difficult piece, is making sure that these patients don't get those wounds back. It's a fight that we all battle every day. Thanks, Dr. Tettelbach. One more question, and this one would be in your realm, Dr. Hansen. Someone saying that for medical treatments, Botox is often not covered by insurance. Is there an effective way to ask for Botox to be covered for hyperhidrosis?
Yeah, good question. Hopefully, the more we can present research to the medical community that it is an effective treatment, that payers will come on board with covering it. However, I think that certainly showing that you have tried other things and that they have failed, if you can effectively describe to your provider the negative impacts of that the sweating is having on anything related to how the prosthesis is working, anything related to your skin health, anything related to your quality of life, all of those things, if they can be articulated in a note or a letter to your insurance, can be helpful. And we've had times where folks have kind of reversed course and gone ahead and approved with adequate documentation.
Thank you. Yeah, I would imagine it's like any other medication where you have to demonstrate that something's not working, and you have to go to battle a little bit for it, which is unfortunate, but if people are persistent, I believe it can be done. Well, that is all for our questions. I'd like to thank the panelists, Guy, Dr. Tettelbach, and Dr. Hansen. It's been a pleasure to be here with you all this evening, and I'm going to flip it back over to Marcy.
All right, great. Well, I'd like to thank Michelle Oliveti and Dr. Hansen, Dr. Tettelbach, and Guy Lev. Thank you all for joining us. Thank you for your support. We appreciate it greatly. I do want to mention to please, if anyone has questions after this evening that didn't get asked, please reach out to us at limbpreservation.org, info@limbpreservation.org. We will answer your questions and we will integrate them with this webinar. Lastly, I have a symposium. It is a new symposium. It was really well received last year, and we are going to make that symposium larger by inviting candidates to come as scholars. We will pay for your participation. You just have to get in touch with us and fill out an application and scan this little QR code that you see right here. If you qualify for financial need, come to the symposium, come anyway. And it's a great way to network, to learn, to celebrate our progress, and to really, just get together and meet a lot of wonderful people. So we would love to see you next year at our symposium. It'll be April 21st during Limb Loss Awareness Month. So with that, I just want to again thank our very talented panel of speakers for joining us this evening. Thank you for all of our partners, with all of your partner organizations, with MyMedics and Swedish, University of Utah, UC Health. I'm not sure if I'm missing anything, but if I am, I apologize. We just really appreciate the partnership with all of you. And thank you again for joining us this evening, and talk to you soon.